Okay, and as that is queuing up, I just wanted to welcome everyone to our second meeting for, I'd like to welcome everyone to our second meeting for House Bill 413 for Medicaid amendments, looking at an integrated model of healthcare delivery for our TAM population. So we are going to begin this meeting first, just introduce myself again, Jennifer Strohecker, Director of the Division of Integrated Healthcare, also serving as a Medicaid Director. And we appreciate your attendance here in this meeting. If you would please, those of you who are assigned working group members, would you please enter your name and affiliation into the chat so we can keep track of our attendees for the purpose of our meeting minutes. If you would please do that, we would appreciate that. And as we launch our meeting today, we realize we have 1 hour, which is a pretty short period of time to address the items even on our agenda today. This meeting today will be 1 hour. Future meetings, which are held every other Friday at this time, will be held for 1.5 hours. So please note that schedule change. And the purpose of that is for us to be able to really have a little bit more time to dive into our issues and have the robust discussion we need to have this meeting move forward and reach our goals of this working group. As we begin our meeting today, I'd like to first just highlight what was covered in our last meeting by going through our meeting minutes. Those of you who are working group members should have received a copy of these meeting minutes. And if you could, Sharon, just display these minutes. Now, I'd like to just go through these together with you for this first meeting and make sure that, first of all, as we look at our participants, we did open our meeting by having an introduction of our members. Each of our working group members were able to introduce themselves and state their affiliation as well as sort of their goals and objectives for being here. So we appreciated you doing that. We did take some time. Executive Director Checketts did give us an overview of the TAM population to give us a context of the history of this population and Medicaid coverage policy with regard to this population. Brian Roach, the Assistant Division Director for the Integrated Healthcare Division, did go through utilization data. The purpose of our review of going through utilization data was to help us have a context of what our population today is using with regard to the behavioral health resources, physical health resources, and other items that are received through billed claims. There was a very nice discussion around this, and as you see, that's captured here, many questions and answers, dialogue, and we appreciated the engagement we had through this. As you can see, there are action items that were put in the meeting minutes. We have some of these action items finished and ready for you today, and we have put them forth in a written document, which we will also share and also post to the website. If there is time, we can go into those, but we do have them available for you in written form. And we can always refer back to this data. I know that as we went through this data initially, there are a lot more things that we're interested in. We can go back and look at our data differently if we'd like to around the utilization information that we have. Representative Dunnigan then took a few moments to go through the framework of House Bill 413. And he and Brent Kelsey walked through the goals and objectives of this working group, helping us understand what our milestones are and the important work that we're undertaking through this meeting. Then we ended up closing our meeting by getting some feedback. We had some time to talk about some open issues that do exist today with some claims payment, reimbursement issues, some of the things that problems we are facing with our current integrated UMIC plans, and some of the issues we wanted to put on the table for discussion so that we could attempt to address and resolve these issues and move forward in our conversation. With this, I believe it does summarize our minutes and the items that we did have an opportunity to address in our first meeting. I would like first of all, to see if there is a motion to approve the minutes as presented, or if there are any individuals who'd like to comment on them.
Jen, Pat Fleming here. I looked these over and they look pretty accurate to me, so I'd make a motion to approve the minutes as presented.
Thank you. Julie?
Yeah, I just wanted to make one point of clarification from the last meeting. I know that there was a discussion that a concern about the enhanced fee schedule and how the ACOs were paying out the enhanced fee schedule. And it was stated that Select Health was the only ACO that was paying out the enhanced fee schedule. And we did confirm with, I believe that was comment was made by Odyssey House's, and we did confirm with Odyssey House's CEO that we had resolved that issue as Healthy You back in April as well. And so I don't know if that was reflected in the minutes, but I just want to clarify that we were paying the enhanced fee schedule within 2 to 3 weeks of receiving it from the state. So I don't know if that was in the minutes or not, but I just wanted to make that clarification.
Thank you, Julie. We can capture it for this.
Great.
For the minutes for this meeting as well, if it wasn't captured in the prior minutes. And we will actually, our next few minutes of time is meant to address some of these outstanding issues that were brought up in our last meeting. If the content of the meeting minutes are to your, if they meet your level of satisfaction, then we can move forward with approval unless others have any concerns.
No concerns. I would just second the motion to approve the minutes.
Thank you. All in favor?
Aye.
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 Okay, thank you, everyone. So motion passes to approve these minutes. We'll put the final meeting minutes on the public website for your evaluation. So to Julie's point, the next few moments we wanted to spend on outstanding operational issues. And first of all, we would like to recognize and just vocalize our appreciation for your willingness to share your concerns and issues that were brought forth at the last meeting. We know, first of all, that you do have concerns, and we have taken a look at these concerns. We understand that, first of all, with regard to the global issue of reconciling the discrepancy in the rates, following our meeting last time, we did reach out to each of our ACO partners. They each provided written feedback to Medicaid, reporting that they had updated the rates and reprocessed all claims. So that information should be up to date. With that being said, we do recognize that there were some individual billing issues where perhaps an inappropriate NPI was billed, or some just claims processing issues had been identified. And those issues are being worked through one by one with those of you who have identified that this has happened. We are working through those with you. So, but we wanted to just clarify that this global issue of this rate discrepancy from our, that happened several months ago should be addressed and resolved. As far as the larger issue, we do recognize a couple of you may have some outstanding issues. And we do believe if we do not have record of those, we would like to hear from you so that we can continue to work through those with you. So the other piece as well is that some other information that we found as we've evaluated the concerns that have been brought to Medicaid's attention is, first and foremost, it is our priority for you to have your claims paid and to have them paid timely. As part of our normal way of doing business, we sometimes do encounter claims processing issues. These are things we deal with our providers on a daily basis, and we want to facilitate appropriate claims payment. We want to work through these issues with you so that we can proceed with our business. There are times we were aware of a couple issues this week that were brought to our attention around communication that had occurred between the behavioral health provider and the ACO, where there had been an amount of dialogue going back and forth where Medicaid had not been engaged. We would encourage providers, first of all, to engage with us in a timely way so that we can help you with these issues, okay? While we know that you may be able to work these out between you, if there's an issue where you're unable to successfully resolve an issue, please engage us in that conversation so that we can help facilitate, we can look at the claims, we can evaluate what the claims processing issue is. If it's a larger issue, we want to work on that with you as well. With that, many of you know Dave Wild on our team. He, I believe at all of our behavioral health and UMIC meetings will state that we want to work with you on this. And Dave will continue to reiterate, he is really our point person who can work with you on this claims identification and resolution of billing things. He can also escalate these things to leadership if these things are not being addressed timely. And so we've asked Dave, and Dave, if you could please put your contact information in the chat. For those of you who do not have Dave's information, here it is, and we are going to be collecting these issues. So we were made of an issue of a provider who'd been working with an ACO provider and had not reached resolution. We've been able to reach out to both this provider as well as the ACO to help work through this issue. We also are aware of this issue around reimbursement for individual services where it could exist in a bundled claim. And this would be, example would be for the intensive outpatient claims, where we need to work as a department to get our claims put together into a bundled rate. And this is being put into our working group meeting this week to be worked on, and we are going to prioritize this work so that you don't have to bill all the individual codes, but we're working to get a bundled rate put together. All of these items, as they come to our attention, are going to be tracked. We're going to collect them, and we are going to bring them back to this group so that you have visibility to the different types of problems that we are made aware of and the status of working through those problems. And we hope that this is a way that we can facilitate positive conversation and proactive work in problem resolution with our partners, yet not necessarily like bring it for discussion in this working group setting. If there is a global problem that we're identifying, we want to bring that to this working group, and we will do that. But we're committing to engage with you directly. Please work with Dave or myself, Eric Grant, and we will happily engage with you and work with you on these issues. We are collecting them. We will bring them back to the working group so there is transparency in the items that have been identified and the progress that we're making. Are there any other comments, questions, feedback as we give this proposal to you? Is there anything else you would like to see or any other considerations you would like from us from your perspective?
Jennifer, it's Russ. I
Correct.
would just reiterate again that if there are any issues with Select Health in any way, shape, or form, I gave my cell phone number the last time, and people can contact me directly. And I've reached out directly to people after the meeting last time. So we want to resolve problems immediately and want to hear about it. So thank you.
Thank you, Russ. Okay, thank you, everyone. And please, if there's any feedback, we're willing to take any thoughts or ideas that you have. Another item I just wanted to update you on before we move into our next agenda topic is also our updated rates. There was a communication sent out last week as well that communicated our July 1st rate updates for both our residential treatment and also for our methadone rate, the daily rate for methadone administration, and for the services tied with methadone administration. So an email was sent both to our accountable care organizations, as well as our prepaid mental health plans, that would notify you that these rates have been updated and will be live in our system on July 1st. And so notification has been sent to all parties. Let us know if you need more information on that, and we're happy to give that to you. Are there any items that you'd like to bring up for discussion around operational issues now before moving on to our next topic?
Jen, this is Pat Fleming again. A question I would ask, the ACOs, I believe, have contracts with most of the governmental agencies to provide TAM services, plus most of the private nonprofit and private for-profit agencies that provide TAM services. Is that correct? Russ?
Sorry, Pat, I wasn't sure if that question was directed at
Well,
me.
it's directed to all of you, but you're
Yeah.
front and center on
Yes.
the screen there.
Yeah, so yes, we have contracts with the providers today who provide TAM services with the majority.
Okay.
Medicaid, and Medicaid can speak to this, but they did an assessment of that, kind of a gap analysis maybe 6 months ago. And we had the majority, Select Health, I'll speak for Select Health, had the majority of providers, and we're closing the gaps on those that we didn't have.
Okay, thanks. And Julie, I would imagine you too. Okay.
It's the same for us.
Okay, thanks, Julie. So one thing I guess I would suggest, Jen, is, I think the last meeting was a lot of concerns about payment and timeliness of payment. If we have contracts, especially now with the governmental organizations, they have some reserves that they can afford to miss a couple payments and still make payroll. But a lot of the private nonprofits, especially in Salt Lake County private nonprofits, they don't have that kind of cushion. And so that's really is the issue. And I've talked to several of those providers since our last meeting. And I guess I would like to suggest this. Since the ACOs have contracts with everybody, and it's a long-term contract, what is it, at least a year, maybe more than that? Or is it ongoing contract? Julie and Russ?
Well, provider contracts are long-term typically.
Okay, good. So if that's the case, I guess one of my suggestions would be this. Why don't we go ahead and pay the claims when they're submitted? And then we can go back and reconcile those later on. Why hold up all the claims for reconciliation when we're looking at making payroll? I think I would say that's the way we used to do it in Salt Lake County, and it worked well because we had long-term relationships with people. And I think if this is a partnership going into the future with this really vulnerable population, that would be a good faith effort to do that. And it would be fairly simple. Nobody's going to get away with anything. Everybody is being honest and good partners in this. And so that's one thing I would suggest that we try to do. Now, I realize if there are some technical issues, I understand that, but to not hold up the claim, submit to pay it, and then go back and reconcile later would be my preference, I think.
Hey, Patrick, this is Brian from Molina. Sorry, I wasn't able to jump on, but we've come up with another way to deal with that that seems to be working. So I'm happy to talk to you or anybody else that wants to talk about that. It's kind of a prepayment type of an issue.
Okay. Okay, Brian, that'd be good. Thank you.
Yeah, thank you for sharing your thoughts on this. We will take this back for a conversation, and we will we'll bring that back. Okay, thanks for the thoughts, Pat. Okay, anyone else? Okay, thanks everyone. We're going to move into, I'll transition over to Brent Kelsey, who will review our other aspects of the TAM population, and I'll just transition over to you. Thank you, Brent.
Thanks, Jennifer. Can everyone hear me? Just thumbs up. Okay, great. I've been having some camera and microphone problems. I think I have them resolved this week. So I'm the Assistant Division Director within the Division of Integrated Healthcare. And we've had a lot of internal discussions about how to structure this meeting to get us moving in a direction toward figuring out long-term what we do with targeted adult Medicaid. And I've been really pleased with the discussion we've been having internally, because I think we're in agreement that the best way to structure this conversation is around the needs of the client. What's in the best interest of the client? How do we develop a system that truly meets people's needs? And so I think that, having worked with so many of you on this call, I think most of you would share, if not all of you would share, that perspective. And I think what we want to do in this next section, and this is going to be contingent upon your participation, is we want to identify those things that are working successfully in TAM from both a physical healthcare perspective and a behavioral healthcare perspective. And so let's start there. I guess what I would, before we do that, just as a reminder, we provided a tremendous amount of data during the last meeting about diagnoses and about the services that were received. And just as a reminder, you saw a tremendous amount of chronic conditions within this population: diabetes, pneumonia, hypertension, depressive mood disorders. Substance use disorder was the leading chronic disease found in this population. And then we also saw that this population is receiving services through pharmacy, through primary care, through substance use disorder treatment providers, mental health providers, the emergency rooms. And so this is a population that's really hitting all components or elements of our healthcare system. And I guess what I would ask to kind of kick things off today is, in terms of physical health and managing the conditions that you're seeing in the TAM population, can someone, a provider or an ACO or a member of this committee, identify some of the strategies that you think are critical to successful management of the targeted adult Medicaid population?
Brent, Pat, I'll start first on this. I think one of the key things is really good sound case management. These individuals have a difficult time negotiating, and I think good case management with some innovative ways of getting people into services is really important. I just look at the population from Fort Street Clinic, for instance, and they're a very, very unhealthy population. They need a lot of services. And from what I remember is the case management services for those people, to keep them making their appointments, getting the places they need to be, helping them with housing if possible, and all those kinds of things are really sort of the key thing, because we really do want to keep them out of jail, and we want to keep them out of the emergency departments. And I think that's really one of the ways to do it.
That's interesting, Pat. We've had the same discussion here, that care coordination, case management are critical. What else are you seeing?
I think access, I'm kind of building on what Pat said, the population has difficulty navigating various systems. So even accessing our systems where we may have more skill or more ability to be flexible. But I think, and so a strategy that understands the difficulty in access is important. And it can come down to nuts and bolts things like scheduling and availability. But, also I think Janita might have brought this up last time at this layer that you're talking about, Brent. Case management and access is made easier when things are kind of integrated under one roof, kind of health home concepts where all of the care can be provided as much as reasonably possible in one place. But I think that's just something important to think about as we're thinking about strategies.
That's great. Others, what in terms of physical health, we've talked about how do we engage this population in preventative care? Is anyone doing that successfully, or have a model where we're getting engagement in preventative care?
So I can chime in a little bit on that. I mean, it is really difficult to engage this population in preventative care. Some of the strategies that we have found to be successful in that have kind of already been touched on a little bit, but like a significant amount of work from case management and care coordinators around like targeted event type days. So we do a men's health day, we do a women's health day, and our care coordinators and our case managers do a lot of combing through our medical record in advance for that. So we can be flagging like, who is it that hasn't been in for her pap smear in the last 2 years, to be doing a lot of outreach. So a lot of that work on the back end to sift through your medical records and kind of come up with your targeted list, and then doing that outreach. So we use our community advisory board, our patient advisory board. It could be a role for peer support to do some of that outreach, to do some one-to-one education with people on why you want to come in and do your fit test, or why you want to come in and have your PAP. We try and do it all, like Kathy said, at once. So we'll do PAP days, and we'll try and have a mammogram bus on site at that same time. So you can do your mammo and you can do your PAP, and it can be like kind of a fun environment to do that. And then also, you know, in that process, you know, give away some hygiene stuff. A lot of women need feminine hygiene products, and then just like clothing and stuff like that that you need as a woman. So, and then patient incentives, I think, are the other part of that. And I know that's tricky with Medicaid, but like being able to offer a gift card to a grocery store or something like that, oftentimes will get people to be more interested in coming in for some of those preventative screenings. And then knowing that they have like we have a disposition for them after the screening, right? So if we're going to do a colonoscopy, or if we're going to do a fit test, and we know that, you know, there's the potential that we have a colonoscopy that's coming up, understanding where that individual can go to access that service, which helps with Medicaid. That's more of a barrier for uninsured. But oftentimes the prep for that is really difficult. And if you are living on the street, or even if you're staying in a resource center, you are not going to be able to do the prep for a colonoscopy. So we will put patients into a hotel to help them get ready for that procedure.
That's great. Thank you. Dr. Whittle.
Yeah, I love that description, and I really appreciate that CCBHCs have been a part of the discussion. I think that's fantastic. You know, it really comes down to that system of finding a strategy to reimburse for the screening, then integrating that reverse integration where we're pushing medical services into behavioral health care settings and finding a way to support those. And then that, you know, I think that's where the care management, case management connection comes in, where that information is picked up and individuals that need further care are able to be transitioned into that further care without the, you know, I think that's where one of our biggest risks lies, that you know, that transition, people fall through the cracks. And so I think those three steps, and I think a lot of pieces have been put in place. And so cohesively putting those together, I think we create a great service. And, you know, I would underscore that CCBHC strategy, because it seems to have key elements of that sort of packaged in to create a framework that can be, you know, even if a program isn't a CCBHC, the framework would then exist, and elements of that strategy that other providers would like to adopt can also be supported. You know, in geographies that have implemented CCBHCs, they've also taken elements of that strategy and, you know, I hate to use the word trickle down, but they also implement them in clinics that are not fully CCBHC, but are providers supporting the strategy.
Great, thank you. Russ.
I was just going to, yeah, thanks, Brian. I was just going to build on the comment about care management. The piece that we've also added into that is community health workers, and utilizing community health workers to, so kind of at the high level, we identify those who were having trouble engaging in care management, and then community health workers can reach out to them, find them in the community, and then their role is to assess not just their physical health needs, but the social needs, and address those, because often that's what's preventing them from addressing physical health and behavioral health needs, but then help them navigate to get those services met. So many times what we see with individuals who don't engage are those who have fragmented care. So you can see that they are getting care periodically with primary care, occasionally with behavioral health care, but they have behavioral health diagnosis and primary care needs, but they're disengaged from the system, and therefore they end up just in the ED and inpatient. And so that's where community health workers has really helped us a great deal.
Okay, thank you. Julie, you're next, and then I'm going to pivot a little bit to behavioral health. But if you have additional comments from physical health care providers, put a comment in the chat, and we'll capture it, and maybe we can schedule some agenda time next time we meet, or we can discuss it. But Julie?
Yeah, just kind of echoing this concept that the care coordination is key. One of the things that we have learned is that in the state prison and in most of the jails, while the individual is still incarcerated, the jails are doing risk assessments on folks. And this risk assessment is a very, very thorough risk assessment. And as we're looking to implement these programs, one of the suggestions I would make to help us be able to coordinate that physical behavioral health care better is if the ACOs could get access to those risk assessments the jails are already doing, because then we can see right out of the gate what are some of those needs that the individuals have. So that's one piece. And then the other piece, and that I think I would love to see this group kind of talk through, is when an individual leaves the jail, their application for TAM can't process and can't be submitted until they've left the jail. And I'm not sure if that's a federal regulation or if that's a state rule, but what that leads to is there's a gap in coverage for the member within those first couple of weeks as DWS is processing their application. And when individuals, are released from the jail, that's kind of when they need those care management transition services the most. They're only given a 15-day supply of medication when they leave. They have transportation issues, all kinds of things going on there. And with that gap in coverage, I would love to be able to see that change and see if we can get people's applications processed before they leave. That way we can step in immediately. We don't lose touch with them. We can have the jail hand them off to us, and we can kind of take it from there, because otherwise what we might run into is, a couple weeks out, you lose sight of the member. You're not able to connect with them because it's a little bit of a transient population. And so I don't know if that's something we can talk about. And then also, historically, I know that individuals are placed on fee-for-service for a month prior to being placed in a managed care plan. And again, that lag time can potentially lead to gaps in care, because I've been told that, if somebody is going to, commit a crime again, they do it pretty quickly after leaving jail. And so if we can be that point of intervention before, those are kind of a couple of other things I was hoping that we could address and look at.
That's a great idea. Eric, I see your hand. Let me pivot a little bit, and I think we'll get to some of these other issues. So in behavioral health, our system, the counties, providers, the ACOs, we've all been working on some fairly unique strategies to do some of the same things we've been talking about, to provide case management, care coordination, to get people where they need to be. Sometimes these things occur within the Medicaid benefit. Often they occur outside of the Medicaid benefit. And I think that's an important distinction. But, when I think about the things that we do in behavioral health, housing, sober living, drug court and problem solving court coordination, ACT teams, medication management. But what other things do we do in behavioral health that helps this population be successful?
Brent, Pat again. One thing, and I think maybe the ACOs are exploring this a little bit, but our state Medicaid office has been wonderful in terms of how flexible and creative it's been with billing codes. And I think it's been wonderful. But we have a really good model already, which is our capitated prepaid plan. And I'm wondering if maybe the ACOs couldn't experiment with several of the larger providers to actually do a sub-capitation to them. Because I don't think we're ever going to be able to get the flexibility in the Medicaid codes to be able to do all the things, just as you said, all the things we need to do. But maybe we could do that if we sub-capitated somehow and just tried that as a model with some willing providers that are willing to do that, and give them the flexibility to do some creative things as long as it stay within that sub cap. And I think that would be a really good thing we could work with the ACOs on.
Okay. Others?
So again, this is Brian. We've posed that to the association, and we did have some providers that were interested in doing that, but it wasn't nearly as many as we thought. So if you want to look at that, or and it doesn't even have to be a sub-capitation. It could be just a kind of a prepaid amount, similar to what some other commercial plans do.
Okay.
Again, we're open.
Great. So just to introduce another issue, so targeted adult Medicaid quickly became the largest payer for people involved in the criminal justice system. And we were able to expand access pretty quickly because it was a fee-for-service opportunity. And so we have new providers essentially in the public system who may not have had relationships with county local authorities who are now engaged and involved in serving the public client, and that's great. And as we work with our stakeholders at the state system, there are other state agencies that are watching this very carefully. And so after our first meeting, Eric Barker from the Utah Department of Corrections reached out and wanted to share his thoughts, concerns. So Eric, you're on the call. Do you want to take a second?
Absolutely. Yeah. Thanks, first of all, Brent, for inviting me. Some of the stuff may iron itself out a little bit. When we first had kind of communicated, there was a big concern in regards of services for our population. That's the justice involved. So we work directly with individuals that are coming out of the prison system. Typically, there's about 3,000 to 3,500 individuals that get released every single year from our state prison. And a lot of those are going to qualify for targeted adult Medicaid. And I wanted to speak a little bit to what Julie had talked about, because just like she had mentioned about the jail, we do a very comprehensive risk assessment too. Like those are things that we can work together with other medical providers. And we've shared that with other behavioral health providers that we work with in the community. One thing we have worked with on targeted adult Medicaid is those that are a serious risk. We kind of roll the dice and actually get those applications for targeted adult Medicaid submitted early and then put those on hold. So the day they get released, we can put those in place, but we have to be very specific on those dates, because as we know, there's that 12-month period. And if we send it 6 months early, that 6 month, we're going to lose off the tail end of it. So we have to be very careful when we're submitting those, because you're exactly right, Julie. If we submit those on the day they get released, there's that lag period. There's that gap before services can actually become available for them. So I'd love to have more discussion on how we can work more closely on that. I think we as an agency do really well working with behavioral health services, but when it comes to physical health things, there's so many limitations that whether it's HIPAA or whatever, but we can absolutely work more closely with the population you guys are serving as well. Because me, say as an agency, I'm dealing with these people that are coming to work with you. I'm going to help have reminders. If you're trying to get a hold of them, I have information that you probably don't have that you could reach out to me and I can get a hold of them to connect the dots so they make sure they make it to their appointments, follow up with their medications or any of those things. So one thing that kind of ironed out a little bit, Brent, since we last had talked, is that through Senate Bill 179 that's on there. So that was our GRI approved provider. One of the big worries for us as an agency is we have people that disperse once they get out of prison throughout the state. So we have very few providers, say in a Vernal area, other remote areas of Utah, could be Moab. And so if they weren't part of that ACO network, we could have offenders that we supervise that can't get services in case they go to other cities or counties. So that was a big worry of ours and one of the main reasons we reached out. But I think with this Senate Bill 179, that's going to iron that out, because there isn't this JRI approved provider list that's going to be locked in place like it has for several years.
Yeah, great. Thanks, Eric. Dr. Whittle, I see your hand.
Yeah, absolutely. And I really appreciate those comments. I think there may be some solution in creating a kind of a subcontract. But one of the big concerns we have about the whole health model of care is that, we have to penetrate much deeper into the mild and moderate needs. And I apologize for saying this, but one of the reasons we needed TAM to go fee for service was because of the access issues that exist within our system as a whole. So, I think an issue like expanding services, filling in gaps, really probably requires an all-willing and qualified hands-on deck strategy. What I've seen in other geographies is kind of a stratified strategy where there's kind of essential folks with very clear roles and strategies to help them fill in all these gaps we're talking about, and then tiers below that start to fill in gaps that need to be supported with kind of the all solutions. For example, those B3 services, which the state had a lot of foresight in starting to flesh out. As you go down from the essential providers, those additional services that can be put in a waiver that flesh out some of those services to help connect the pieces can really bridge some gaps. And so, and then, providers who, my apologies for wandering on this, but it's a big topic.
Yeah.
I think one of the strategies ACOs really bring to the table is that they have been willing to look at the network more comprehensively and have been willing to contract more comprehensively, and then working together to define that and categorize it in a way that meets the needs of our populations more effectively, I think could be ultimately the best strategy for us in terms of access.
Thank you. Adam, we'll take another comment here, and then if you have other thoughts, put them in the chat. And then we're going to pivot to one more discussion item before we start thinking about some, other business issues.
Yeah, thanks. So I just wanted to, I'll try to be as concise as possible, but I think what we're seeing when people come to the door, this population is very marginalized and have not really accessed services in primary care or behavioral health care. And so in most cases, the people who are coming to the door are coming with the clothes on their back. And for some of the criminal justice involved individuals, they're coming in with tattered clothes because of an altercation with police when they came in, and they're maybe out of date for seasons. So we're starting from basics with these individuals. They don't have driver's license or social security cards. So we're having to walk them through all of the basic things that we all take for granted, but we do as an organization, and all the other providers are doing as organizations to help them be successful. And I think just pivoting back to the primary care discussion, again, they haven't accessed healthcare in any meaningful way in many years. And so rapport is huge. And so if we're attaching to them, they're trusting us as the provider, and we're incrementally building that trust over time and addressing some of the highest pressing needs for them early on, and having some wins with them to make them feel better, having symptom resolution, and then kind of teaching them about what's the appropriate way to access healthcare. I think finally, to Pat's conversation, I think we really need to have a conversation about this being episodic rather than that the treatment should be paid on an episode level rather than a per day or a per service level, so that we can really be more flexible on all of the things that we need to do to address this population. I think we get bound by a day rate or an encounter-based rate. And I think that really is the future of where we should be going, is identifying this as a chronic disease, with identifying both all behavioral health as chronic disease for the most part in this population, that we really we're in it for the long term with these individuals. It's not a month here or a month there, that we really want to have them attached long term and go into maintenance phases and still remain attached. So those are my 2 cents.
That's a great comment. Thank you, Adam. This was an ambitious discussion, and it doesn't quite end here. I know that there's a lot more that this group could bring to the table in terms of successful strategies, and I hope that we can continue this discussion going forward through our series of meetings. But the other question we wanted to pose to you today, and the bill poses to us, is about defining success, and how should we define success with this population. So, as we talk about it internally, SAMHSA provides guidance to our system about what recovery looks like, or what success looks like in terms of behavioral health. And they've defined recovery, and they've defined the elements of recovery in terms of health, home, community, and purpose. We had an internal discussion about the triple aims, and evaluating where we go with this group in terms of, cost, access, quality, equity. So we have established quality measures, really in behavioral health and physical health. We have satisfaction surveys that evaluate what clients want and need. But in terms of metrics or outcomes, who has some thoughts or ideas about what the plan should be for targeted adult Medicaid? What should we really be paying attention to?
I am going to jump in here because I think, Brent, you and I have talked a little on the side about this, unless I'm missing what you're asking, but I feel that these, it's harder for me to think of metrics in terms of specific cases or specific agencies, because although we're all trying to accomplish the same end goals, I think, people enter the system and focus on certain pieces of their health issues, whether it's behavioral health, physical health, psychosocial stability issues, that they kind of set the agenda individually. But I think if we had access to, does treatment reduce hospitalizations over a 1 or 2 year period? Does it reduce ED visits? That's an important one too. But I think when it comes to big costs, if we need that kind of long view, as opposed to patient satisfaction or completion of a treatment episode. We need what's happening to this person in terms of the larger healthcare system that we can't access as individual agencies or providers. And I think hospitalizations is a big one, mortality, of course, housing, justice involvement. Is the investment that we're making with TAM dollars circling back and creating better health and better function and less costly individuals in our system?
Great point. And you think about the eligibility for TAM and criminal justice involvement. I hadn't really thought about, in terms of outcomes, criminal justice involvement. That's something that we've always evaluated in our system, but really hasn't been a part of TAM. And that's an interesting point. So we're going to have to continue this. Well, other comments on this before I push it back to Jen? Oh, there's a lot more to discuss here, I know, and so we don't have a lot of time for this discussion today. And I would be curious in a minute or two, suggestions going forward. I think that we need to continue this discussion around metrics. There'll likely be other strategies that people want to bring to the table. We'll work internally to try and take your comments and structure the next agenda to keep us moving forward so that we can accomplish our goals. But if anyone has suggestions or ideas for our next meeting, why don't you can bring that quickly and then I'll give it back to Jen. One suggestion I have is I think we need an hour and a half for this meeting because I think we've finally got people engaged and thinking about these things, and it's time to go. So we talked internally about adding a half hour or making sure that this was an hour and a half meeting going forward. We'll make that change. And other thoughts, comments? Okay, well, we'll work internally to kind of structure your thoughts and keep this moving forward. Jen, do you want to, anything that you want to say?
Yeah, and I'm really sorry if we cut off. We asked a big question, right? Like,
Right. Well, we've got a few minutes.
What are some metrics for success? And I certainly don't want to interrupt that thought. If you have them, please keep bringing them forward. What we wanted to do at the end of each meeting was to just offer a time for Q&A. So this is not set dialogue. And we need to continue thinking about what are our metrics for success. I think one of the things as we've met and thought about what our goals are is, first of all, is to really remain like whole person centered around what the needs are of this population. It's why we first brought utilization data. What types of services is this population utilizing? What are we seeing from claims data? It's why we tried to touch on today with Brent's initial, opening conversation and dialogue with you was like, what are some things that our data isn't showing us? What types of wraparound services? What are these metrics for success around the unique needs of this population that we need to think about? I know he touched quickly on medications, but being the pharmacist in the room here, I'll say like what we've heard from you too is like adherence to injectable antipsychotics, staying on your meds is so critical to success in other areas. Like, it is important for us to really dissect and understand what the needs are so that we can actually build the right framework for solutioning what this integrated model will look like. We touched on case management services. What type of case management services, right? Is it a case management load that, this person the case manager needs to be engaged routinely on a weekly basis, on a more frequent basis? Is it okay for infrequent? Is it individual? I mean, what have you seen? These are the places where we really need to have your input to make sure that when we build this model, it meets the needs of the population. I really enjoyed hearing also about, the meeting, the one-stop shop and the ideas that have been done around making sure the prep work is done. So when they go into the clinic, all the resources, the research has been done around the needs that what are needed. So we're going to capture all of these in our minutes. And I think we've talked about subgroups and blowing this out into like longer meetings. And I think we have a lot more discussion even around these ideas that we want to do. But I think the other piece that I do want to just also touch base on is eligibility. There are two different areas of eligibility that were addressed today. One was the waiver that has been submitted to CMS around early enrollment prior to being released. That has been submitted to CMS, and the feds are working on. They haven't. I put in the chat that we're waiting on the feds. I think there is some work being done around justice involved folks, and there's more global national work being done on that. So we've been waiting on them, but there are also, to Representative Donegan's notes, tools that have been put in place with DWS around early enrollment prior to being released from jail. So we want to bring that back as a topic for next meeting. But we stopped kind of just into this conversation around what are some metrics or some outcomes for success. I think really this time is set aside for Q&A. So what are your thoughts are there ideas that you want to put out for immediate discussion, just to really capture the needs of this population and to do our work as thoroughly as possible so that when we build the framework of the integrated model, we capture the needs and really best practices properly. And then I also do want a framework with, I love the brainstorming. We do have to work within our CMS, requirements and the limitations that we have there and sort of the framework that CMS does put forth. So, but anyway, I'll just stop talking for a minute and Brent certainly facilitate on through here in the last
Sure.
2 minutes.
Well, and we've talked about case management and we've talked about care coordination. I think that begins at the I think this population needs help with enrollment assistance beyond what may be available in certain areas. And so I think that's something we ought to consider also is, and I love the discussion about, with Eric and corrections and the jails and their potential role in helping us with that. So I think there's plenty for us to continue with in terms of this discussion. Suggestions, feedback, comments about how to structure this meeting. The time is yours. Representative Dunnigan.
Thank you.
The time is always yours.
No, thanks. As a follow-up to our last meeting, you presented, I think it was you, some wonderful data on the utilization, and Jen referred to it. Everybody may not be interested in that, but we asked some more specific, such as emergency department, things like that. Has your team had a chance to evaluate that, dig through that data? And if you don't want to take time in this meeting, next meeting to go through it, I'm wondering if you could send some of that more detailed information out so we could get a better understanding of the utilization.
Yeah, so Brian Roach, and we'll be sending this out with the minutes. Is that right, Jen?
Correct. And I think Sharon actually had the tab here. So if we want to look at, we've begun, it does take some time to really evaluate this data correctly. So we've begun answering some of the questions that you presented. If we want to go through this quickly, we'll just give you a very high level view of what we've been able to pull together so far. And Brian, if you want to go ahead and speak to what we have here, that would be great.
Yeah, I'm happy to. So the three main requests that I addressed in this 3-pager. So first is the trend of PMPMs. That's on page 1. Shows by service categories, some reduction in PMPM over time, which does kind of reflect an increase in the enrollment growth, the member months through this public health emergency maintenance of effort. The second is aggregate expenditures quarterly. So among those categories, what's the aggregate expenditures? Those values are in thousands of dollars. And then the third page is some utilization trends. There's no real benchmark that I could think of to compare this to. So I hope you may bring some recommendations or interpretations to the meeting next time. But these are expressed in encounters per 100 member months. So if there's a value of 100 in this chart, that means 1 encounter per member per month. Just keep that in mind. So at the height of utilization, like 2018 to 2020 pre-pandemic, it was about 6 services per member per month. And you can see the breakdown by service. And in recent quarters, it's decreased to about 4.5 services per member per month. It's very high level. But I'm presenting that to the group here, and as mentioned, it will be distributed in the minutes.
Yeah. So, and we'll bring more data, and we can have discussion about this in subsequent meetings. But we did want to try and be responsive to the questions that were raised. And Brian's an incredible resource. I don't know. I'm just moving over here and getting my feet wet. So it's amazing what we do have. And our fear is that if we brought this information to you at the beginning of this meeting, we could easily have spent the whole hour doing nothing but trying to evaluate this chart together. It's really fun to engage with, but we had to be careful about our time. So that was the strategy, at least in our thinking. We're at time, Jen.
Hey, Jen, this is Pat Fleming. Can I mention something before we
Yes.
leave? The USAID Council, the Utah Hospital Association, and actually your division, Jen, we're working on a master plan for behavioral health services for Utah. And this is both the public and the private side. We've engaged with Kim Gardner and Levitt Partners. And what we will be doing is a series of focus groups on these. So I just wanted to cue you all up on this because a lot of you will be contacted to participate in these focus groups. So I just want you to know what's going on there. So what do we want our behavioral health system to look like in Utah in 10 years? I mean, that's really what it is. And of course, this is really related to the TAM population in a big way. So I just wanted to cue you all up on that. If you get an email from her, the woman's name is Brooke Zollinger from Levitt Partners, or Janita or myself will also reach out to you too. So just be aware of that. You may get an email asking to participate in a focus group. Thanks, Jen.
Yeah, thanks for the announcement on that, Pat. Anyone else that has one last comment or so? Okay. If not, we appreciate your attendance today and your many contributions you've made to this meeting. We will see you in 2 weeks for an hour-and-a-half meeting. And at that point, we'll continue to the dialogue here with the items that were brought up today and some new things. Thank you, everyone.
Thank you.